Direct fibre reinforced bridges are a minimally invasive, efficient and low-cost alternative to replacing missing teeth. Every patient presents with a unique clinical challenge, and I have specifically chosen these patients to show the wide range of treatment options that are available with this technique. The direct fibre reinforced bridge creates happy patients and is a sound practice builder. The upper left canine is a fibre reinforced resin crown that will be used as an abutment tooth. Trichloroacetic acid chemically cauterizes the gingival tissues, stopping clavicular exudates. An antidote solution of sodium bicarbonate is kept on hand when TCA is being applied. An access cavity is prepared to just over 1.5 mm deep and 1 mm wide on the mesial aspect of the abutment tooth. A carbon fibre post, composite post, is tried into the preparation prior to cementation. Fuji-Bond LC is placed into the cavity and over the posts. A fibre reinforced composite resin, New Light F, is placed into the preparation. The carbon fibre post is carefully positioned into the preparation to form the central core of the pontic. The preparation is light cured for 20 seconds. After cementing the post, Fuji-Bond is again smeared over the exposed post and a white tint placed to opaque out the black carbon rod. Spot cure for 5 seconds. An increment of New Light F is placed onto the carbon rod and carefully puddled around it to form the outer layer of the reinforced core. Cure for 20 seconds. Resin bond is placed over the lingual surface of the pontic and abutment tooth. An increment of New Light F is placed over the lingual. A resin-impregnated section of ribbon fibre is placed onto the composite resin. The preparation is photo-cured for 20 seconds. A microfill resin is next placed over the lingual surface to cover the fibres. Prior to photo-curing, a 3 cm square section of freezer bag is placed on the uncured resin and the patient asked to close. The facial aspect is spot cured prior to opening and curing the lingual surfaces for a further 20 seconds. The lingual surfaces will only require a slight adjustment to clear the bite. A paladin sexual matrix is inserted under the pontic core with a concave surface against the abutment. This will form the contour for the gingival floor. Stabilising the matrix with a finger, an increment of capsulated Fuji 2LC is injected under the core and adapted with a plastic instrument. Still holding the matrix in place, the resin-modified glass ionomer cement is photo-cured for 20 seconds. Resin-modified glass ionomer cements produce a better tissue surface than resin. A micro brush is used to place resin bond over the facial surface. An increment of cervical shade microfill resin is puddled onto the pontic with a Wurtz carver and the matrix is gently pushed into the gingival margins. The area is spot cured for 5 seconds. Bonding resin is placed again. An increment of body shade microfill resin is placed onto the pontic and contoured into shape with a Ward's carver. A small amount of white tint is placed into the resin and characterised onto the surface. Spot cure for 5 seconds. The lingual aspect of the sectional matrix is levered away from the pontic. A paper point is gently wedged into proximally and a mylar strip inserted. Positioned lingually between the pontic and the matrix. With the mylar strip secured, bonding resin is placed over the preparation. An increment of incisal shade microfill resin is placed proximally and worked over the incisal edge and onto the lingual margins. The strip is folded over the facial surface to facilitate the formation of the proximal margin. After spot curing for 5 seconds, the facial and lingual margins are each cured for a further 20 seconds. After placing a bonding resin, the proximal area between the abutment and the pontic is formed using an increment of incisal shade and forming it with a Ward's carver. The whole restoration is now photo cured for 20 seconds. The matrix band is removed with a pair of pliers, followed by the paper point prior to finishing. A 12-fluted tungsten carbide burr is used for initial cervical contouring. Bulk reduction of facial and incisal surfaces is carried out with a Moore's extra coarse emery disc. Lingual contouring is achieved using a high-speed round diamond burr. Lingual contour will be minimal due to prior occlusal adaptation. Finer contouring is carried out with a small, coarse, soft-flex interproximal disc. When the disc is reversed, it can be used for contouring the proximal surfaces of the bridge. Final occlusal adjustments are carried out with articulating paper registering centric, protrusive and lateral movements. It is essential that all occlusal interferences are identified and completely removed. A high-speed pear-shaped stone provides initial facial contouring. Polishing is commenced with a silicon rubber wheel on both facial and lingual surfaces. Proximal finishing is carried out with flexible abrasive strips. Dental floss confirms the absence of any roughness on the proximal and gingival surfaces. A final polish is carried out with a small, fine, soft-flex disc. The lingual view shows the reinforcing fibre. spatial view shows the natural contours and gingival adaptation that can be achieved using this construction technique. I've been providing these direct resin bridges now for over 25 years. While nothing works in 100% of the time on 100% of the people, there are many patients who have been very happy to have received one. They're a great way to build your practice and a challenge that will enhance your enjoyment as a dental practitioner. If you'd like some more information about this technique or other videos in the series, I can be contacted on the following email or fax numbers, or check out the website. And thanks for watching this video.